Welcome, everyone. Today, we're going to break down Dr. Patricia Flores' fantastic lecture on corneal ectasias. Our goal here is to really distill her key principles and protocols into a clear, practical roadmap that you can use in your clinical practice. Okay, so here's our plan for today. We're going to start with the basics of ectasias, then get into the official classification system. After that, we'll do a really deep dive into keratoconus itself. From there, we'll cover treatments, walk through a specific protocol for fitting lenses, and then we'll wrap it all up with the most important takeaways. So let's just set the stage here. You know, the vast majority of our patients, maybe 70–80%, they come in with regular corneas. Those are pretty easy to manage with conventional lenses. But then there's this other significant group, the ones with irregular corneas. And these patients, well, they require a completely different, much more specialized approach, and that's exactly where we're going to focus today. I love this quote from Dr. Flores because it perfectly frames what we're talking about. What it's really saying is that expertise in this field isn't just about what you learn in a book. It's forged in the clinic, through experience, through trial and error, and honestly, through the perseverance to learn from every single case, especially the ones that challenge you. You know, for a long time, irregular cornea was just this big, messy catch-all term. But then, in 2015, the global consensus on keratoconus and ectatic diseases came along and brought some much-needed order to the chaos. It gave us a clear, structured framework that really helps us classify, diagnose, and manage these conditions in a systematic way. So this classification really lays out the whole family of these degenerative thinning disorders. You can see the entire spectrum here, from pellucid marginal degeneration all the way to post-LASIK ectasia. But the main event, the condition we see in over 70% of all our ectasia cases, is, of course, keratoconus. And because it is just so common, we're going to spend this next section really digging into keratoconus in detail. What are its characteristics? How does it progress? And what are the key factors that are actually driving it? Now, for decades, keratoconus was defined as being non-inflammatory. That's why you see that word historically in the definition. But our understanding has really shifted. We now know for a fact that inflammatory factors, things like cytokines and interleukins, play a huge role in its progression. And if you need proof of that inflammatory link, look no further. A staggering 90% of patients with keratoconus also have underlying allergic conditions. This is absolutely not a coincidence. That chronic inflammation, and maybe more importantly, the eye rubbing that comes with it, are major biomechanical triggers that push this disease forward. Understanding this timeline is just vital for how we manage these patients. The disease usually shows up around puberty, and it progresses most actively until they're in their mid-30s. This active window is precisely when an intervention like corneal cross-linking can be most effective at stiffening that cornea and hopefully halting the progression. It's important to remember that not all cones are shaped the same. We generally see two main types. The oval cone is bigger, more common. The nipple cone, on the other hand, is smaller, more central, and has a much steeper, more abrupt change in its curve. Recognizing this shape is everything, because as Dr. Flores puts it, tell me the shape of your deformed guitar, and I, as an artisan, will create the shoe for your deformed eye. In other words, the lens design has to match the specific morphology. And prevalence isn't the same everywhere, not even close. You see this massive 100-fold difference between the US back in the 80s and modern Saudi Arabia. And this is where we really see the impact of environmental factors. For example, in the mining zones of northern Chile, where the ozone layer is damaged and UV exposure is incredibly intense, the incidence of keratoconus is just dramatically higher. So it's pretty clear at this point that there's no single cause. Keratoconus is truly a multifactorial disease. It's really the perfect storm of a genetic predisposition, biochemical changes happening in the cornea, the biomechanical stress from eye rubbing, and then environmental triggers like UV rays and allergens. Okay, so what happens when just managing with glasses isn't cutting it anymore? What's next? Well, we have a range of procedural and surgical options, and the real key is knowing when to use each one and why. This flow, which comes right out of the global consensus, gives us a really logical clinical pathway. But what I want you to notice is the central role that contact lenses play. They are the primary tool for rehabilitating vision when glasses fail, and they are considered before we even think about moving to more invasive surgical options like rings or transplants. It is so important to distinguish the goals of these different treatments. Intracorneal rings. Their main job is to reshape the cornea to try and improve its optics. But meta-analyses have shown they do not halt the progression of the ectasia. The only treatment that's been proven to significantly slow or stop the disease from getting worse is corneal cross-linking. And this really underscores the profound impact of what we do. This is not some minor intervention. By successfully fitting these specialized contact lenses, we are fundamentally changing patient outcomes, helping nearly 2/3 of them avoid a major surgery like a corneal transplant. That's huge. So this brings us to the real heart of our clinical practice, having a systematic protocol for choosing and fitting the right lens for the right patient. This whole approach is designed to take the guesswork out of it and ensure we get a successful outcome. This is it. This is the fundamental question we face with every single one of these patients. And the answer isn't about having a favorite lens type or brand. It's about having a methodical evaluation process that guides us to the absolute best technology for each unique cornea that walks through our door. And that protocol rests on these 3 pillars. First, you have to understand the patient's full story. Second, you have to become an expert at reading topography maps to truly understand the corneal shape. And third, you have to define the visual goal. If you follow these steps, you ensure a comprehensive assessment before a single trial lens even touches the eye. And this table here gives you a really clear starting point for that decision. It's not about the brand, it's about physics. For a mild ectasia, a specialty thick, soft lens might be all you need. For a moderate central nipple cone, a corneal RGP is often the perfect choice. But for those advanced, large, or peripheral ectasias, or for complex post-surgical cases, that's when a scleral lens becomes your go-to tool. The cornea dictates the technology we use. So as we start to wrap up, let's try to distill everything we've talked about into just a few core principles. Think of these as the things that should guide our daily practice when we're managing patients with ectasias. These 5 points are really the foundation. First, allergy control is non-negotiable. Second, remember these patients often carry a heavy psychological burden. Our empathy is just as important as our technical skill. Third, this is a team sport. We have to work closely with ophthalmology. Fourth, use your entire toolbox of lens designs. And finally, success is built on consistent, diligent follow-up. And we'll end with this question. It's really a challenge for all of us to look beyond the topography maps and the fluorescein patterns. Our role isn't just to fit a piece of plastic onto an eye. It's to leverage our expertise to restore vision, to provide comfort, and to profoundly improve a person's ability to live their life. That is the true measure of our impact.